Hey, Lifespans class, this is Dr. Ang. I am touching base with you again regarding chapters 3 and 4. We had some techno issues in the classroom, so we were able to hit some of the highlights, but I wanted to touch base with you again and just kind of re-emphasize some of the things that are critical from these chapters. And again, this is birth, through the delivery process, and then into the newborn stage. So I wanted to run through that. If you pull up your PowerPoints, starting in chapters 3, we'll take off there. Okay. On the first slide, we will start. Some of the key points here is remembering that there are roughly 10,000 babies born every day in the United States. So given that's kind of reflective of when you fast forward that's going to be our workforce, and just as we go through the population of what's the contributing in society via our workforce, and then as we transition later in life to the care that we'll be giving on past retirement, and then into the later years as well. So I have percentages there. You can see I have made it accessible for you to see my notes in some of these, so pay attention to that as you go. Then we transition into the stages of labor, knowing there are 3 main stages of labor. To break it down very skeletal, just know that stage 1 is going to be the dilation to a 10. Stage 2 is the delivery of the baby, and then stage 3 is the actual delivery of the placenta. And upon the delivery of the placenta, then the delivery is considered complete. You can go to the second slide there, referring this 3 stages, and you can see a little closer, a few more details of there, of showing the delivery of the baby. Then we move on to the next slide, slide 4, that's referencing what's normal and abnormal. I have included a video there. It's a little bit more bent towards the nursing perspective, going a little bit deeper than what you're going to need for purposes of this class, but it is informative nonetheless. So if you want to look through that, you can. You don't need to be worried for the exam purposes that you're going to need to go that deep, but it does give a very good reflection as far as abnormal and then normal regarding the newborn. Upon the newborn assessment. APGAR, we have 3 newborn assessments that are critical. Once that baby is born, as the healthcare team, we're going to take these on. The 3 are APGAR scoring, Brazelton, and then we have the Brady scale as well. So Ballard's score. So actually, instead of Brady, we're going to, for purposes of this class, the third one we're looking at is Ballard score. So APGAR, you can see it's appearance, pulse, grimace, activity, and respiratory effort. So as the baby is delivered and handed to that healthcare team, there's a lot of these that we can assess with practice, just right off the bat. So you can tell I don't necessarily need to listen to the respiratory efforts of that baby, but if I have a brisk cry, then I know that I'm where I need to be as far as scoring for APGAR for respiratory effort. So some of these can be spontaneously graded, especially if that baby, we want that baby fighting and lots of energy displayed and not flaccid and laying back. That's indicative of a premature infant at times, or that there may be some respiratory distress. Grimacing, you can see if that baby is crying, they're grimacing. Appearance, everything should be bright pink, almost to red if they're giving us a brisk cry. So all these, you can see, even going to the next slide, you'll see severely depressed, and that's an emergency situation, is going to be if the baby receives a 0 to 3 on the APGAR score. Excellent condition is 7 to 10. If you fall somewhere in the middle, moderately depressed, that's going to be somewhere 4 to a 6. That may be a baby that needs slight stimulation, kind of just get a little jump start going on, may need to be monitored, may even need a little oxygen to get going. But if they fall 4 to 6, usually they're going to be okay and be able to still go out for that golden hour with mom or a caregiver. But knowing that 0 to 3 is an emergency situation. So scoring that's the APGAR scoring. And just to remember that, you can see again, A for appearance, P for pulse, G for grimace, A for activity, and then R for respiratory effort. And that is the first one of our newborn assessments. Then we move into the Brazelton neonatal behavioral assessment. This is the one that's just going to give us, it's a wide range of things that it's looking for, but it's more behavioral. And we can go into the first 20 days actually with this one. And there's different behaviors that if we're having trouble bonding, we're having trouble with reflexes, lots of areas in this you can look and see that this covers, but this is going to be indicative of, hey, we're going to need a little bit of help, maybe long term, or there are some areas that are of concern that we need to provide resources to stabilize this child or to help support long-term optimal outcomes for this child. So we're just looking for more warning signs. This is not initial stabilization score such as the APGAR is. That's more just to make sure that we're monitoring that process from intrauterine to extra uterine life. How did they tolerate that delivery process? So that's more of an emergency and urgent score that affects right now. Brazelton's, though, is kind of looking out. So let's look at the first couple of weeks here. How are we transitioning? What signs are we seeing? Are we having trouble? It was a premature infant. We're having trouble with suck training. If that is the case, then we may have some growth and development issues that we're going to need to address. So we're just looking at behavioral clues. Is the infant having trouble bonding? Is there some attachment issues that we're looking at? Are there reflexes that should be present, primitive reflexes that are not there? Just different things. Is the baby not following clues on the visual pattern? Maybe we should pursue some extra evaluation or refer them to a specialist, an eye specialist. Just different things that would be indicative of there may be problems down the road, so they need resources now. So that is the Brazeltons. You'll know in chapters 3 and 4 there are significant slides on this. It also provides a little history of the different people that have developed these scales. So that's kind of interest as well. But chapters 3 and 4 somewhat mirror each other. So I'm hitting on some of the key concepts, but you can find information in either section, in either folder. So there's additional information in the PowerPoint as well as resources in chapters 3 and 4 folders. So look at those in Harvey as well. So then we go into the Ballard scale, and that is the third newborn assessment that we're going to look at here in these chapters for lifespans. So you can see with this one, we have several categories there that you can look at, and this is more of a commonly used scale, a scoring method to know, kind of trigger the gestational age. So how we mentioned term baby is 38 to 48 weeks. If we get a mom that's not sure, she hasn't had prenatal routine prenatal care that we have seen specifically of what gestational age this child is, the Ballard scale is going to be more indicative of that. So you can see the posture, the arm recoil, scarf sign, different things you can see. This is a score that we will, like as a newborn nursery nurse, you would do, and you can say, okay, they said this baby was term, we were 39 weeks. Clearly we're not, because based on the Ballard score, this baby is maybe a 35-week baby, which would present, you ask yourself, why would that really matter? Now the baby's born. knowing that that final trimester, or those final few weeks, is when there's more maturation taking place. We're developing the more fine tuning on respiratory things such as the lungs. The lung maturation is critical during those final few weeks. So we're going to want to monitor that baby differently if it's a 35-week baby compared to if we're thinking it's a 39-week baby. So these are different scores that are important for the healthcare team when providing optimal care for that baby. So knowing that the Ballard score is indicative of a accurate gestational age, and that's the third one. Moving on to physical appearance of the newborn, we mentioned in class the cheesy, greasy substance that you see often in photos of a newborn baby that they're covered in is the vernix. It's usually dark, but doesn't have to always be, but the dark fuzz is lanugo. And then the milia is typically found on the bridge of the nose, maybe forehead, can be on the chest, back, shoulders, and that is often referred to or thought to be like a baby acne. These are all three conditions or temporary findings that we will find in a newborn, and they are also common. They are normal. So these are not abnormal findings, these are normal. And I mentioned in class that the vernix, that cheesy-like substance that I'm going to show another on, you can see on slide 10, that is something that oftentimes new parents want to get that washed off in that first bath when you're taking the pictures, and that's such an exciting time. They want that washed off, but that is golden for that baby's skin. So the more that you can leave on to kind of absorb in, it just kind of adds a protective layer for that newborn. So that is a normal finding. So vernix, lanugo, and milia, just know what those are. And if a new mom says, I need to get a prescription for my baby has baby acne, you can share with them that is probably just the hormones, her natural hormones coming out in that baby. Very short-lived, within probably a week, at the most 2 weeks, that's going to be completely gone for the most part. So another normal finding, and does not need to be treated. Then we discussed bonding and the attachment phase and how important that is for Erikson's first stage of trust versus mistrust. So in those initial stages, how important it is through the feeding process, that golden hour that's so critical now, that research, it's evidence-based, that research shows that initially after delivery, we have, as a healthcare team, we have an entire list of things that we want to check off, a checklist that we need to get done immediately. And now research is showing maybe some of that can wait, because what's critical is that golden hour when that baby can bond. And in the cases, some cases with mom, maybe that's not who is ideal to bond with that baby. So if it's maybe that baby is going up for adoption, or maybe that mom has had a significant delivery process and needs to rest, then that baby can go with dad or another caregiver and still get that. We're even doing golden hour where we go skin to skin, chest to chest, baby to dad. So whatever that looks like, that bonding is critical. And it's called the golden hour because right after delivery, we want that baby skin to skin with a caregiver that will be in that baby's life. So that's the bonding. We also discussed the importance of that there is someone there and what that looks like if there is a baby that's maybe there is no caregivers there. There's not, maybe it's going into the foster care system and there's not somebody in place yet. So how can that be achieved? So maybe it's a nurse, maybe it's a sitter, whoever we can have just to be having that formal period of time where there's a bonding and it can be a close connection until a stable caregiver is in place. But regardless, nonetheless, we need the bonding to take place so that attachment can start forming with that human-to-human connection, and how important that is for trust versus mistrust and forming that solid foundation from day one, hour one of that baby's life. Next stage, we'll go into, let me pull this down, Erikson's trust versus mistrust, as we've mentioned. The baby is asking the simple question of, can I trust the world? What just happened? I was in this safe, very predictable. I didn't have to worry about anything. Food, oxygen, everything was there. And all of a sudden I went through a very traumatic event of the delivery process. And now I'm outside in this somewhat scary world. It doesn't feel as safe to me. I'm used to being in this position and I could barely move, but I felt like I was getting a constant hug. To now I'm out into this scary world. And is someone going to scoop me back up and meet my needs? Or am I going to be left to fend for myself? And can I trust the world? When I cry, will someone come? When I'm hungry, will someone feed me? When I'm cold, will they clothe me? These are the questions that now they're asking from day one. So that's basically met, and they're not going to ask in words, but they'll cry, and those needs will be either met or not met. And that's determining whether they can trust or they're going to mistrust, for mistrust with the world around them. Okay. Now, approaches to childbirth, knowing that that is very different for everyone. It's very subjective. Everyone has their ideal picture in their mind of what they want that to look like, and we're there to support that. Pain is very subjective, so some will want very little for medications to support the birthing process, while others will be very adamant that they are induced and it's controlled and monitored the entire time. And that's fine. Whatever they want, we're there to support that if you're in the nursing role. But just knowing that there are lots of options for that. The key that I wanted to pop back on here and mention to you is we want to know, pay close attention to the added risks associated with the preterm infants and birthing complications. This is the area that I want you to really touch on. Knowing that a low birth infant is 5 pounds 8 ounces and under, and along with that's usually a preterm infant that's going to have the low birth weight. But we have extra complications due to respiratory, feeding patterns, all these things, and typically is going to also be associated with, on the Ballard scale, it's going to show gestational age to be very young, as well as we're going to have several things on the Brazeltons that we're going to need to have on our monitor. And the APGAR score right away is going to be dropped down, most likely into closer to that 3 mark, hitting below 4, where we're going to know that we're going to look at a NICU stay. And to a family that's looking to bond, and sometimes they know that they're more than likely they're going in and now they're going to have their baby early. Sometimes they don't, and it's an emergency situation, and this is completely new and a surprise to them. So educating them on what this looks like and offering them hope, most of all, because we have a lot of resources, healthcare resources in place to be able to help them and support the optimal outcomes of their baby. But just knowing that that is an emotional stressor for parents going into that and the caregivers. So when we think of the complications of everything that should have formed and been kind of solidified, or at least the maturation process would have happened in that final few weeks when they're growing birth weight at a significant rate. Now we know, okay, we have all of that should have happened, and that last few weeks is going to now need to be supported by the healthcare team, possibly in the NICU. And on top of that, we're going to add a complex. We just discussed how important it is for trust versus mistrust, and forming that bonding and attachment process. Now, how is that going to look when that baby is in the NICU and mom and dad or caregivers can't just come and go as they please? How, when that bonding you can't have that golden hour right after delivery. The baby is swept away to the NICU, and the healthcare team is frantically getting everything in place to support their needs at that time. And when the feeds used to be, maybe the mom was going to breastfeed and form that connection, or at least a minimum of feeding, bottle feeding, and having that interaction where that baby is looking at mom's face. And now the feedings for that baby are going to be through a tube, and maybe they're inside of their crib where they're not able to be touched. So how does that look for bonding and attachment? All things that kind of add to the complexity of a premature or low birth weight infant. So 3 and 4, look at all of that, because there's going to be reflexes that aren't in place, just a lot of things. Doesn't mean there's not hope. I remember when I mentioned in class as well, you can go into the NICU, and I encourage you to walk up and down the halls and see how young that some of the babies gestational were born. 27, 28 weeks, low 30s, 32 weeks. And then you can see them graduating high school and all these things. So it's not that we don't have most cases, we're going to have the outcome are going to be, it just may not look exactly like the caregivers had planned or the parents had planned, but we can support still a very significant life and supporting that. Viability, we mentioned, has typically been at 25 weeks. Now we're dipping down in 25 weeks, and viability only means, it doesn't mean we're going to have a perfect outcome. It means we have a 50-50 chance that they're going to survive outside of the mother's womb. That's what viability means. You can look at that picture there and see. Looking at slide 17, you'll see that graph. You can see I've put a golden arrow dropping down at that viability state, and you can see through that thing, oh wow, like all of this has happened. First, second trimester, we're cruising, we're doing great. But then note everything that happens after that gold arrow as well. So there's a significant amount of maturation that happens that is left in that stage. Also pay attention to the factors associated with risk for low birth weight, demographics. We mentioned, depending on where you are, you may be in a very rural area. There's a lot of places that it's very challenging to access health care. In some cases, the mom wants it. In some cases, she doesn't. So, but if you're trying to access health care and it's difficult, I mentioned to you in class, just trying to access, okay, do I have to, maybe I work a job and it's very difficult to get somewhere during their office hours. Finances may be an issue. Maybe I have kids, and how do I get them there? Maybe I don't have a vehicle, I don't have transportation, therefore I need to use the bus route, and how does that all look? So it doesn't necessarily mean that the mom doesn't want to access prenatal care, but in a lot of cases it could be challenging. There are medical risks that could be involved if mom has a pre-existing condition. And concepts of risk, so we know of prescription or non-prescription drug addictions that we can have, smoking, alcohol, different things as well. And then just an overall lifestyle of environmental risks that could be involved with that as well. There's also the risk of post-mature babies, and then cesarean deliveries. That's pretty cut and dry. Just note, what I wanted you to see that we weren't able to tap into in class is I want you to see the videos that I've included with this, because it's going to give you, you're going to be able to read it, you're going to be able to hear it, and then you're going to be able to see it. I like to come with a trifecta effect of different things that are going to be important concepts. Knowing postpartum blues, and then depression. I have psychosis on here, but focusing on, we need to educate on postpartum blues, that's okay. The honeymoon phase will be over. You're going to be hormones everywhere, and you're going to be low on sleep. And you may have some thoughts and feelings that, wait, this isn't the picture that I had in my mind going in. And that can kind of come and go. And just know that that's okay. And it's okay to express that. And you need to let your healthcare provider know if that starts to linger, because then it might move in more to depression and kind of set in. This is also, if you've suffered from depression before pregnancy, you're probably going to suffer from postpartum depression after pregnancy. So that would be kind of a red flag to be watching for. But even if you don't, blues can tend to linger and lead into postpartum depression. And if you ever have any signs and symptoms, or the mom does, that we need to encourage them to seek care and seek help on there, and so that they are familiar with the resources. We want them to have the resources in their tool belt before they go home. So when these things happen, they can pull out, oh, here's a number. They told me about this. They said this is normal. It's okay. I can call and get help for myself and thus for my baby. Look at the infant mortality rates, and again, knowing that this is very indicative of the premature infant. And then I just have some other slides that kind of show you as we're going. Remember cephalocaudal development, and let's see which slide that's on. That might be in the next one. And then proximal distal, but I say cephalocaudal is knowing that the baby's going to lift their head. Okay, they're going to start to push up, then they're going to roll over, then they can get where they can actually sit up. They're going to try to start to pull up, then they can take steps holding on to something, then they're going to break free and start to walk. That's cephalocaudal. It starts with the head. Remember I mentioned they have a large proportionate head with a small body, and that neck has to try to support that. That's why it's so important that we support the neck and the head for the newborn initially. We got to let that body grow into the size of that head. So as they go, they're going to get that head strength through the neck, and then it works its way down. So cephalocaudal is head control, and then pushing up, as we mentioned, that works all the way stair steps into the baby actually walking. So head to toe development, head to toe assessment, you can kind of remember that, is cephalocaudal. Proximal distal is they master from the inside out to the fingertips, the legs down to the toes. So an example of this is, I mentioned in class, you're holding your baby, having a sweet moment, and they just clock you right in the face. They can get that large movement in much quicker than they can get putting Cheerios into a small bowl. So that would be more of a fine tune. So the gross motor comes before the fine tune, and that kind of makes sense. And that's proximal distal. So these are some key components. A lot of this transitions over into Chapter 4 as well. Also, it will touch on the senses and knowing that that baby's visual acuity is going to be about from mom's eyes down when you're in the feeding position. And then it continues to fine-tune throughout that first year of life. But knowing at delivery for the newborn, that's how it is, that they're very, their visual acuity gets better, as well as their sensory as far as hearing. They've been hearing the entire time they're in the womb, so that's why comforting positions are right by mom's heartbeat. That's why they can calm a little easier with that, or just, again, they can form that bonding attachment with another individual as well. But those noises and the voices that they heard are going to be familiar to them, as well as they have a good spot perception as far as if someone walks in the room of a nursery from a door, they can turn right to that direction. So that's indicative of that their hearing is further advanced, typically for the newborn. The other senses as far as taste that there are, they can go through for sweet. They will prefer sweet. That's why we can also give little drops of sugar water for trying to comfort a baby for a procedure, different things. But checking all of that, it's important for growth and development and feeding patterns right after birth, that we're looking for that meconium stool is passed. That lets us know that the GI tract is all working properly, as well as we're going to check that palate and make sure that the suck reflex is there, so that we can optimize good feeding patterns right from the start. So those are all things that are going to jumpstart into, not only because these are being met, trust versus mistrust, it's going to set our feeling of trust and that foundation for that baby, so that as we continue to grow, we're going to build on each of these. And then that is Erik Erikson's stage that we are writing on for the reflective paper that will be due on Tuesday. So I hope you have a great Labor Day weekend. I just wanted to pop back in and let you know we are working on the technology, the Collaborate, trying to get all that in place. But I wanted to just highlight some of those areas for you and let you know if you have any questions whatsoever, please reach out to me. My contact information is in Harvey, and I'm always happy to help. Have a great weekend. Bye-bye.